Thank you, Tex, and thank you for that nice opening. My name is Adam Olsen. I'm MLA for Saanich North in the Islands, and honored to represent this beautiful part of the world in the BC legislature. Over the last few years, since the emergence of COVID-19, maybe a little bit before that, but certainly COVID-19, Sonia and I have been spending a lot more time on the healthcare file. And there's no doubt that since my election in 2017, and even back to when I ran in 2013, healthcare was a number one topic, or a top topic, let's just say. I don't want to. There's a couple of number ones, I think, in the riding. So that means that there's no number ones, but certainly healthcare has been a top issue in our riding. And back when I was first elected in 2017, in fact, Adrian Dix came and did a community town hall with me in Sydney in those earliest days. And so I'm really glad to be joined this evening by Karen Morgan. I think Karen will turn on her camera here in just a second. And we're going to split this evening into, we've got a couple of presentations, a couple speakers, and then we'll have a Q&A at the end of it. Karen Morgan is joining us for the first part of this evening. Welcome, Karen. She is the outgoing interim executive director of the Shoreline Medical Society, formerly the president and CEO of the Saanich Peninsula Hospital and Healthcare Foundation, and was really instrumental in the evolution of the Saanich Peninsula Hospital Foundation, turning into the Saanich Peninsula Hospital and Healthcare Foundation, and really been a very strong voice on the Saanich Peninsula for the provision of healthcare and the connection and the linkage, the critical linkage between the delivery of primary care and the impact on one of Saanich Peninsula's most important resources, and that's the Saanich Peninsula Hospital. And really, that connection has been made. And Karen, you've made that connection very clear for me as the MLA here, and I really appreciate it. So Karen is going to join us this evening to talk about healthcare. I'll let you fill in the gaps of any of the other part of your background. You got an extensive bio here, but any of the other parts of your background that are applicable here. But I just want to introduce Karen Morgan.
Thank you, Adam. And I think in the interest of time, I'll leave out all the detours I've had in my life. I'd like to also thank the Saanich North and the Islands Riding Association for inviting me tonight. I feel really honored to be presenting along with Dr. Sanjiv Gandhi. And I hope you'll enjoy our presentations, and I hope you will have lots of questions so we can have a great discussion. I'm going to go through 5 key areas that I think are important for you to understand. I'm starting with a bit of history, and I'm going to end up with what I think we can do now. But before I do that, could I have the next slide, please? I just wanted to start with a little humor, because if we don't laugh, well, I think some of us start to cry. So anyway, we'll move on from pearls before swine and go to the next slide, please. The first area I wanted to talk to you about is Medicare is not as old as you might think. It started as hospital and not healthcare insurance. In 1947, the Saskatchewan government, led by Tommy Douglas, introduced the first hospital insurance program in Canada. And then in 1958, Paul Martin Sr. introduced a national hospital insurance program. And then there was the introduction of universal Medicare, which followed essentially the same pattern. In 1962, Saskatchewan's CCF government introduced the first public health care program. And then in 1966, the Pearson minority government created a national public health care program. And this is a really important point. it was originally set up with Ottawa paying 50% of the provincial health costs. At that point, citizens would receive portable, comprehensive, and universal access to necessary physician and hospital services, regardless of their ability to pay. However, it took until 1972 for all of the provinces and territories to actually get the program implemented. So 72, if you're young, it might seem like a long time ago, but it doesn't seem that long ago to me. Next slide, please. The second thing I wanted to talk about is our healthcare system is much more fragile than you might realize. In 1977, after the OPEC oil crisis of 1973, and during a time of wage and price controls, healthcare costs were rising faster than inflation. The Trudeau government retreated from 50-50 cost sharing and replaced it with block funding. Then in 1986, the Canada Health Act was unanimously passed, and it banned extra billing by reducing federal transfers by the amount of direct patient charges in that province. And it ended user fees for insured physicians and hospital services. With that legislation, I have to say we moved away from what Tommy Douglas originally conceived of as our healthcare system. And I'll quote from him here. He said, "I want to say that there is a value in having every family and having every individual make some individual contribution. I think it has psychological value. It keeps the public aware of the cost and gives the people a sense of personal responsibility. We should have the constant realization that if those services are abused and costs get out of hand, then of course the cost of medical care is bound to go up." Now, what he was talking about here was not a significant cost, but he was talking about the psychological value of everyone paying a small nominal amount in order to feel a sense of ownership and responsibility. So then the next important date is 1994. And that was when the Liberal government was elected with they inherited a record-breaking debt, and the finance minister was tasked with the job of eliminating the deficit. He did that. It was a significant retreat in funding for many areas, but the cost to healthcare was enormous. Cuts to healthcare spending resulted in the elimination of approximately 100,000 hospital beds, I've been told. Then Paul Martin followed up in 1996 with the introduction of the Canada Health and Social Transfer, and that caused massive cuts in transfer payments to health and social programs in the provinces. Now, he got the result he needed. Healthcare spending dropped from 10.2% of GDP in 1992 to 9.2% of GDP in 1995. But that doesn't mean that demand went away. Wait times for surgery grew because of a lack of hospital beds. And many smaller hospitals began to fundraise for equipment as government funds could no longer support healthcare infrastructure, especially the kind of equipment that included technological advances. On a personal note, I wanted to mention that when I first arrived on the Saanich Peninsula in the year 2000, the Saanich Peninsula Hospital was funded to use only about half of its 75 acute care beds. And it took many years to rebalance that funding so that they could open up more beds. Now, the next issue was in the early 2000s when physician shortages began to appear. By 2003, there were 1.2 million Canadians who could not find a family physician. And after reading some of the articles I've read in the last few days, I have to say, isn't that a quaint number? It's now about 6 million, over 6 million. The situation was exacerbated by governments and health authorities introducing the position of hospitalist, and they frequently drew from the ranks of family physicians who had the ability to leave their panels of patients and work set hours on a salary with benefits. And then it was further exacerbated by the creation of private options, the Copeman clinics, which is now TELUS, the Cambie Surgery Center, among other surgical centers, and now President's Choice and others. Next slide, please. So what's changed? There's been a generational change, and I would like to point out that this has been apparent to those who have been looking at this issue for at least 15 years. Young doctors who have been coming into the profession for at least 15 years have decided they don't want to run businesses. Now, doctors originally used to see themselves as business people who were then forced into a single payer billing system. But otherwise, they maintained their independence from government. Now, young physicians, they still want to maintain their independence from government, but they want to work more collaboratively with other physicians and other healthcare professionals. More importantly, they do not want to be business people. They want to be relieved of the business aspects of family practice, and that is one of the ways in which they can help achieve work-life balance. BC has been well behind other provinces in recreating the system. And I can go through what other provinces have done, starting with Quebec creating family medicine groups in 2002. But I will refrain from getting into that kind of detail. And this is another really important point, that family physician compensation, I'm sorry, I didn't on the slide put family physician, but that's the really important thing. Family physician compensation fell behind the pay to specialists, and it also fell behind rises in cost of living, which has been a significant barrier, I would say, that has been artificial barrier that's been put in place, causing those who might have chosen family practice to choose something else. Next slide, please. So in answer to the question, what did we do on the Saanich Peninsula? Well, here's a number of things we did do. First of all, research, and more research. Along with a few people at the hospital and in clinics on the Saanich Peninsula, I started doing research on primary healthcare centers. I looked at the changes in structure of clinics happening in other parts of Canada, as well as recruitment strategies to see what was getting doctors to come, particularly to smaller centers. After learning a lot about what was going on in other parts of Canada, things had gotten much worse at the Saanich Peninsula Hospital. We could not support the doctor of the day service at the hospital, and it looked like we had no hope of getting hospitalists. So the board of the Saanich Peninsula Hospital Foundation, as it was then known, agreed to experiment with physician incentives, which I discovered were working in other parts of Canada. These incentives, which were structured to encourage physicians to both deliver primary care in the community and hospital care through the Doctor of the Day service at Sanpan Hospital, were effective in recruiting approximately 10 new physicians to the Saanich Peninsula. And of that 10, about 5 of them became integral to the founding of Shoreline Medical Society. Next, with the help of the South Island Division of Family Practice and funding from a number of donors who had faith, along with a loan from the town of Sydney, we were able to develop the nonprofit charitable model of Shoreline Medical Society to deliver primary care. Our initial goal was to attach the 10,000 people on the Saanich Peninsula or in the Saanich Peninsula local health area who didn't have a family doctor in 2016 to our clinic. This led to 5 years of incredibly rapid growth. And then when you add in COVID, we looked up at the end of approximately 5 years. It took a little longer because of COVID. We realized that there were now another 10,000 people at least who didn't have a family physician. But because of the pressures of COVID and rapid change, everyone at Shoreline needed a year or two to recover, deal with staff turnover, and generally consolidate the gains that we'd made. Now, you might ask, why did Shoreline work when other things might not have? Well, the key here is that community members worked alongside doctors to implement the model and to make it work for them. The model's built so that doctors can provide care at the hospital, as well as serve their primary care patients. And locum physicians are available to cover patient panels while the primary physician is out of the office. Now, if you're watching tonight and you don't have a family doctor, I wanted to say to you, we are currently looking for ways to expand to make more room for physicians and allied health practitioners. I know it's possible you feel like we don't care about you, but that's not the case. Shoreline Medical Society, the board, the staff, the physicians, everyone is continuing to work hard. But I can tell you from my last 2 years of experience being around Shoreline that it's sometimes very hard to keep building when you look around you and see other parts of the system crumbling. Next slide. My last slide is, what can we do from now? And the first thing I wanted to talk about is focus on community. I'm tired of hearing people complain, why can't the government do about whatever problem they have? In my opinion, government is not omniscient and it's not omnipotent, and tax dollars do not provide a bottomless well of cash to solve problems. The Saanich Peninsula in particular is a strong community with a history of fighting to get the healthcare it needs and deserves and being innovative about getting it. And I believe on the Saanich Peninsula and elsewhere in this province, we need to either continue or build that tradition. The second thing is, and I will say this politely, I don't always, we need to talk to politicians about what it takes to get your vote. And I believe that what you should be getting is honesty about what it costs to run a healthcare system in this day and age. And B, accountability from those who run the system about how funds are actually being spent on our healthcare. The third thing that I think we should all be doing is advocating in the political sphere for longer term decision making. On CBC a few weeks ago, I heard this interview with the most amazing idea. The country of Wales has created a Future Generations Commissioner. Now, it has implications for all aspects of government decision making. And what this person does is counteract the short-term election cycle decision-making that's become predominant in politics. This position was created under the Wellbeing of Future Generations Act, which requires public bodies in Wales to meet today's needs without compromising the needs of future generations via 7 interconnected national well-being goals. And having thrown these ideas out here, I'm going to stop at this point and then turn things back over to Adam. Thank you very much for listening to me.
Thank you so much, Karen. That was fantastic. And I think it's important to maybe link the comment from, or the quote from Tommy Douglas with the key role that the community plays. We just got to spend some time together this past Saturday, where the community raised roughly $620,000, and contributed to healthcare, and so there is that through the healthcare foundation, the hospital foundation, there is that linkage of community back in it, and the same can be said for Shoreline. Thoughts on that?
You're absolutely right, and the Saanich Peninsula Hospital and Healthcare Foundation has been very generous in helping Shoreline get itself established. They provided about $4 million in capital funding, and about $2 million over the years in operating funding to help us meet that gap between what is considered strictly clinical costs and is covered by physician overhead and what is really society costs. And I can tell you that because we have donors, there are a few people who donate directly to Shoreline, but there are also people who donate for Shoreline to the Hospital Foundation. But because those people exist and are donating, I've had many of the doctors at Shoreline say to me, they feel even more appreciated because the community is investing in Shoreline. So I think that's a really important point to make, that it comes back to us, these investments that we make.
Is this almost that, it wouldn't be a complete replacement where there's that individual or that personal responsibility that each one of us carries for the cost of healthcare, that there is a cost to healthcare, that those donations and the foundation and, having the status that the society does is a way to reconnect that value and to show that the community is investing back in it. I was able to stand today and say our community invested this in healthcare. And so to the minister, the implication is, and so then you will be matching. You will continue to match it because we continue to show that we care about healthcare on our peninsula.
And I think, to be fair to governments of all sorts, once you amalgamate within a system, such as we have with the health authorities, you tend to create a system where the smaller communities with the generalized services are not considered quite as important as the tertiary care centers in the bigger cities. And I understand that, if we didn't have the tertiary care centers, where would we be? But from my point of view, I've always said that there is a role for the Saanich Peninsula Hospital in this system. It's not either or. And so we need to keep bringing the message back to government that our community has made investments, but yes, you need to make investments too.
Yeah, exactly. Okay, cool. I'm going we will invite Sanjiv Gandhi Dr. Sanjiv Gandhi back into the room here. And then, Karen, in a few minutes, we'll rejoin and go for questions. I think it's a good time now to just say, before we get to you, Sanjiv, I just want to just say that Linda has put something in the chat with respect to this evening. This evening is hosted by the Saanich North and the Islands Riding Association, and Voices of Saanich is a no-cost event, but we do ask our presenters and our guests to recommend where you could make a small donation or make a donation in order to support the organizations that are being profiled and the issues that are being profiled. In this case, Shoreline Medical Society and Dr. Gandhi's election campaign have been chosen. Election to Vancouver Renfrew. We maybe talk about that in a little bit, but so I just wanted to point everybody to the webinar chat where you can see links if you have the capacity to make a donation to either or both of those organizations. We in Saanich North and the Islands Riding Association appreciate it. Okay, Dr. Sanjiv Gandhi is the deputy leader of the BC Green Party and colleague of mine, and we've just been getting to know each other over the last number of months, and really appreciated Sanjiv's powerful voice in and on healthcare related issues, and really, Sanjiv, appreciate the experience and the expertise that you bring to our organization and the work that Sonia and I can do in the legislature, and how you have been informing us and sharing your experiences with us and sharing your wisdom with us, and it's been very helpful, especially from my perspective, someone who comes from about as far away from a medical profession as you can guess and as you can get to. So I just want to introduce Dr. Sanjiv Gandhi to continue the conversation about the healthcare system and things that we can, where we're at and things that we can do to improve it. Dr. Gandhi, the floor is yours.
Thank you, Adam. And I appreciate the invitation. And just to note that this evening I'm coming to you from the unceded and traditional lands of the Coast Salish peoples, including the Squamish, Musqueam, and Tsleil-Waututh nations. So I'm going to pick up really where Karen left off. I will just tell you that at least one of my slides has a bit of a graphic image in case anybody's bothered by that. It's not that bad, but just a quick disclaimer. Now I'm going to try to share my screen here. Hopefully that works. Somebody let me know if it doesn't, because I can't see the Zoom screen anymore. It's pretty evident, I'm preaching to the choir, to tell you all that healthcare in British Columbia is on life support. These reports of ER closures, inpatient closures, problems with the delivery of healthcare are rampant. They come out literally daily. Well, what qualifications do I have to speak on all of this? Up until the beginning part of 2023, this is what I spent my life doing. I spent the last 3 decades immersed in clinical healthcare. I was a pediatric heart surgeon. I trained in Montreal. I spent almost the better part of 2 decades in the United States and moved to Vancouver in 2010, where I was the chief of pediatric cardiothoracic surgery at BC Children's Hospital. And I've loved what I did, but I've seen the deterioration of the healthcare system in general over the course of the last decade. And my attraction to the BC Greens was that, contrary to popular belief, they thought about many different aspects of society. Although it was a party born on climate and environment, certainly they cared about much more, and healthcare was one of the things that sort of drew me in. And they had clear and consistent science-based policies and guidelines on where healthcare should go in the province of British Columbia. So to get back to the beginning, well, what's Canadian healthcare all about? Why did I really want to come back to Canada from the United States, because I truly believe in Canadian healthcare. The historical nature of this was given by Karen, but what should Canadian healthcare be? In essence, we need it to be accessible to all, equitable, and universal. And right now, we're not meeting those goals. The problems include access, the delivery of healthcare, which is impeded by administration, and the comprehensiveness of that healthcare. So the fundamentals, which often are forgotten by politicians or maybe not even understood by them, is that the number one key to a successful healthcare system is obviously to keep people healthy. The prevention of disease is not just good medicine, but it's good economics. Healthier people are far easier, of course, to take care of than sick people, and they're far cheaper for the whole healthcare system. And in my view, maintaining good health is healthcare. Everything else is illness care, and that's what the system in British Columbia, and in many parts of Canada, but I think British Columbia takes the cake for this one. We've turned into a system of illness care. We are reactive rather than proactive. This slide is well known to all of you, that the percentage of British Columbians without a family doctor has continued to increase over the past couple of decades. It's now 1 in 5 British Columbians, to the best of our knowledge. We don't really get accurate statistics, but approximately 1 in 5 British Columbians don't have access to a consistent primary care doctor. Now, the myth going around is there's a shortage of family care doctors. Well, this is from February of 2023 from the College of Physicians and Surgeons of British Columbia. I get their annual report, and their annual report in February showed that we had 7,300, almost 7,400 licensed family docs in British Columbia. Now, according to the Ministry of Health, and I think this is frankly a lowball number, but according to the Ministry of Health, each one of those family docs should have a patient panel of about 1,250 patients. So 7,000 times 1,000 is well over 7 million, and we're not able to provide care for the 5 million residents of British Columbia. And of course, the reason for that is that a huge percentage of these 7,400 family docs don't practice family medicine. Less than half of them actually practice longitudinal family care. Other family docs or trained family docs are drawn into other aspects of the healthcare system because it's easier for them, it's a more comfortable life, and the compensation is better. So frankly, we have the docs, but they're not practicing the specialty that they were trained in, primarily because the system doesn't encourage them to do that. Recently, the BC Greens released this ad, which promotes how we think this should go, and frankly, how I think this should go, is to promote community health centers across British Columbia. So primary care needs to be more accessible. The UPCC model that's been introduced by this government is a failed model. It's really just an extension of emergency rooms with less capability than emergency rooms, and doesn't provide consistent longitudinal family care. What we need are community health centers across the province with government-supported infrastructure and team-based comprehensive care. Like Karen said, docs don't want to be businessmen anymore or businesswomen. They want to be doctors. They want to take care of people. They don't want to run a business. And the way to ensure that happens is to not have them practice in solo settings, but rather practice in team-based settings. This isn't just good for the docs, it's good for the patients. So these teams should consist not only of doctors, but of nurse practitioners, physician's assistants, physiotherapists, social workers, and mental health professionals. And primary care is really what facilitates preventative care and early intervention so that health issues can be intervened upon before they escalate into more severe conditions, before the cancer gets so bad that everybody needs radiation and we're forced to send people to Bellingham because we don't have the capacity to take care of them. Now, the government recently introduced physician's assistants after years of hammering that we were the only jurisdiction in Canada that didn't have PAs. I worked with PAs for my entire 17 years in the United States. They're fantastic, but in the usual short-sighted approach of the current administration, they introduced PAs only in a very small piece of the healthcare pie in British Columbia, that is in emergency rooms. And it's still not finalized. They're still working out the details. But PAs are an incredibly useful resource, and they should be used in lots of other settings to increase the number of family docs available to practice family medicine. PAs can be useful in not just emergency rooms, but in primary care practices and in operating rooms. Lots of times in small hospitals around this province, operating room assistants, when you're doing an operation, you need an assistant on the other side of the table. Those are family docs. And by virtue of the fact that they're in their operating room means that they're not in their office taking care of patients as they were trained to do. Now, let's talk a little bit about administration. So my problem with the whole we need more money argument is that the money tends to just get thrown down the drain. And this is a representation of administrative costs just in the last 7 years since Minister Dix became the Minister of Health. It has ballooned from an already ridiculous $1.5 billion a year to now over $3 billion a year. Healthcare expenditures in total have gone up $10 billion, billion with the B dollars, in a little less than the last decade in British Columbia, with ostensibly worse outcomes. If you were any other business anywhere on the planet that invested $10 more billion into your business and had worse results at the end of the day, you still wouldn't be functioning, and the leaders of that business still wouldn't be the leaders of that business. And it only takes a cursory examination of the org charts of some of our healthcare authorities to see how bogged down we are in bureaucracy. This is just the first page of the PHSA org chart. It just demonstrates the 13 vice presidents plus general counsel of the PHSA. We're paying these people an average of $400,000 a year, and we have 13 of them in one healthcare authority. This is VHA, Vancouver Island Health Authority. Same thing, a whole host of vice presidents. If you add them all up, they add up to 64 vice presidents among 7 healthcare authorities in British Columbia. Redundancy at its finest. So in my view, and I think in the view of the BC Green Party, major surgery is needed to cut out the redundancies and massive waste in healthcare administration. There are too many vice presidents, there are too many managers, there's too many directors who just soak up resources without any accountability whatsoever and without any responsibility or contribution to outcomes. And I think a complete rebuild of the healthcare administration with a serious look at the functionality and utility of the healthcare authority model in British Columbia is absolutely necessary. We need evidence-based medicine grounded in scientific evidence, which relies on the best available research to inform clinical decision-making. And really, all this bureaucracy just creates impediments that prevent the acceleration of good healthcare. Right now, government, not healthcare experts, dictate what medications to fund, what services to include in MSP, and the quality and quantity of equipment to buy. So my big thing is that improving healthcare is not all about pouring more money into it. It's about improving the efficiency. If you improve the efficiency of the delivery of healthcare, you will improve not just quality, but you will decrease cost. And I'm going to show you a very small example of it in my previous life. So when I came to British Columbia in 2010, everybody said, okay, Gandhi, what's your vision? What's your vision? What are you going to do for the BC Children's Hospital Heart Center? We want to know. What's your plan? What's your 10-year outlook? It was pretty easy. I had 3 things I wanted to do. I wanted to deliver care to any child in British Columbia with cardiac disease that was of equal or superior quality to that received anywhere on the planet. I wanted to develop into an equal partner in Western Canada with respect to the care of children with cardiac disease. And I wanted to enhance the program in all ways necessary to develop into a premier pediatric cardiac center in North America. And I presented this plan 2 years before I actually signed on the dotted line to move to British Columbia. But it took quite some time for the administration of British Columbia Children's Hospital and PHSA to agree that this is something that they agreed with. I wasn't asking for a whole lot in terms of resources, in fact, almost nothing. But I wanted to be empowered to be able to do this and to be able to take care of children to the best of our ability. So when I came, what did I do? This isn't without any increased resources, but I streamlined processes designed to improve safety and outcomes, maximize efficiency, and minimize cost for kids undergoing heart surgery. We rejigged the anesthesia system designed to permit early extubation, which means removing the breathing tube quickly on children after heart surgery. If they've had a good operation, then you can take the breathing tube out fast, which makes things go much more quickly and much more efficiently and safer for the patient's hospital course. We had to make some changes in the intensive care unit. We had to make some changes on what was called the children's heart unit, which was the step-down unit they went to after kids got out of the ICU. And just with these little changes in my tiny little piece of the pie in British Columbia healthcare, and pediatric cardiac surgery is a very tiny piece of the BC healthcare pie, we did a few things. So the green bars are mortality, kids that didn't survive their operations before 2010, and the yellow bars are after 2010. And I think it's also important to note that the definition of mortality, you would think mortality is an easy definition, but it isn't. Before 2010, that mortality was calculated based on 30-day mortality. After 2010, the rules were much more rigorous, and so the mortality was up to 6 months. So despite the fact that we counted a lot more deaths after 2010, or a lot more deaths were qualified to be on this slide, the mortality dramatically decreased after 2010 with the changes that we instituted. And it wasn't just about mortality, it was about morbidity outcomes and how kids did in the short and long term. So just doing these little things, getting rid of the breathing tube early in the operating room, getting kids to the intensive care unit quicker, getting them to the floor faster, getting them home faster, it improved a lot of things. So we decided a couple of years in 2012, we decided to let's start calculating all this. It took us a few years to do the calculations, but the calculations in terms of cost savings. So just those little changes over an 18-month period, the first 18 months of my tenure at BC Children's Hospital, we saved the healthcare budget in British Columbia almost $5 million of just direct costs. We didn't account for costs related to families getting back to work sooner, overall improvement of the economy from a parental perspective. This was just direct hospital costs, $5 million in an 18-month period for a tiny, tiny piece of the pie. So just imagine what could be done in the healthcare system, generally speaking, provincially, if changes were made to improve efficiency. And just a last point on this, this was 4 of my last 5 years at BC Children's Hospital. This data is from a database that we had to put all of the operative information into. And all these terms and such are not really relevant. The left-hand column is just, the left-hand column is just a bunch of different operations which are identified by our governing bodies. And length of stay is, or LOS is length of stay, which is the post-operative length of stay of a child after they've undergone a heart operation. And length of stay is a surrogate for complications and how they've done. So BC Children's Hospital length of stay is column number 2, and STS length of stay compares us to the rest of North America. So STS is 123 institutions throughout North America that do pediatric heart surgery that implant their data into this same database. So you can see for all of these diagnoses, our length of stay was not just a little bit shorter than the North American average, but a fraction of the North American average. Like sometimes 3 to 14 days, 3 to 11 days. The quote unquote worst one was 7 to 13 days. So we're still twice as good as everywhere else in North America. And I don't put up this slide in a boastful manner. I just put it up to demonstrate what can be done with improved efficiency in a healthcare system. And if anybody's wondering, just because we sent kids home faster didn't mean they bounced back to the hospital anymore. The readmission rates actually dropped significantly after 2010. I'm going to pivot a little bit now to comprehensiveness of the healthcare system, the last thing that I talked about initially. And I'm going to use the example of the opioid drug crisis in British Columbia. And again, this slide is no surprise to anybody that deaths from illicit drug toxicity in British Columbia have continued to just skyrocket over the past decade. The things that we've done haven't been enough. And one of the things that we haven't done is really address the mental health problem that underlies many of these issues. And we don't actually have an accessible mental health care system in our province. And what we need to do is include universal mental health care in our publicly funded system. Somehow we treat a broken brain and a broken bone differently, and they should be treated the same way. We need to regulate counselors and therapists and include them in MSP. Nobody has $250 or $300 an hour to spend to go see a psychologist, which right now are not included in MSP. And we need to include social workers as part of the healthcare system. So the bottom line is failing to address the fundamental issues in our system will continue to magnify this cycle that we're in, where demand outpaces supply. The BC healthcare model as it currently exists is suffocated by bureaucracy and politics. But the good news is not only do we need to, but we can fix all of this. And we can do it expeditiously and cost effectively with the right people to make the right decisions. And of course, central to any successful vision is a system that embodies compassion and accessibility. So thank you for your time. And hopefully I'm not sharing my screen anymore, or maybe I am.
No, you still are.
I don't know how to get out of it. Stop share. There you go. Okay.
There we are. All right. Thank you so much, Sanjiv. That was really, I know we raised the questions with Minister Dix this week about, he continues to highlight the amount of money that's been spent. And, I think that as I put a little video out earlier today, just talking about the fact that under his watch alone, you said in the last 10 years, it's about 10 billion. Under his watch alone, it's about 8.4 billion, from what I understand, from his first budget to the most recent one. And the results that we're getting are not there. I mean, we're not seeing a remarkable increase. So we see a remarkable investment. And as you pointed out, it's actually by creating efficiencies that you find improvements in the system.
Yep, absolutely.
So maybe I'll invite Karen back onto the screen here. There's, I think, just to open, I just want to connect the question that I have around Sanjiv talking about community health centers as being the model. And it seems to me that Shoreline Medical Society is following the community health center model. And maybe between the two of you, like just talking about whether or not what it is that the Green Party is proposing and what it is that Shoreline has been building and delivering is similar, and perhaps if not, what are the differences, and what do we need to what needs to be added to that to include, to be able to be profiled as a community health center?
I'll start. Shoreline isn't technically a community health center just yet. That is, it doesn't belong to the BC or the National Community Health Centers Association. But that's because predominantly we have physicians on the board of directors. But the reason why we included, we actually have an equal number of physicians and non-physicians on the board, and it has created an atmosphere of trust and confidence in what we're building on both sides. So the physicians' independence is maintained because they are there to protect their interests, but they are cooperating and collaborating with the community members to build what I think is actually a stronger system. So the other reason why we could potentially be called not a community health center right now is because most of them started with a key populations that they wanted to address problems in. And Shoreline right now, I mean, you could say that because of the age of the population on the Saanich Peninsula, that we do actually have a specific population of patients that we address their needs, but it really is more general, the practice that's provided. And the one area where we are providing specialized service is the youth clinic. So it's, you know, technicalities, but otherwise it is a community health center.
And maybe for clarity, thank you for that, Karen. And for clarity, Sanjiv, community health centers as a term, is that a governance model? Is it a set of services that are delivered? Is it a philosophy of service? Like when you're saying community health centers, what are we saying?
Yeah, I mean, I think all of the above. So, I mean, Sonia's described it well, I think, in making the analogy of community health centers with schools. I mean, the way we treat schools in this province and every province is that we have schools around the province, and we ask the teachers to teach, and we leave all the other stuff up to all the other people. We don't ask the teachers to pay the janitors. We don't ask them to buy the paper clips. We don't ask them to run the administration of the school. And that's what community health center really is. It's one-stop shopping. So it should have family docs, it should have specialists, it should have on-site diagnostics, and the administrative aspects of it shouldn't, I'm not saying they should be run by government, because when you put a healthcare authority in there, it becomes a disaster, but they should be financed by government. And that would go a long way to taking better care of patients and improving costs. And there are those models, but the government has not enhance those models. I mean, the primary example is the community health center that existed in City Center in Vancouver, which was called a UPCC, but it really wasn't. It was a 3-floor deal, and the government actually asked Seymour Health to put this together in 2017 or 2018 because they knew they couldn't do it. And visiting the place, I mean, the first floor was an urgent care center. The second floor was a bunch of family docs. The third floor was specialists, including obstetricians and orthopedic surgeons. There was on-site diagnostics, so blood work, you could get it and get your results back in a half an hour. You didn't have to go to Life Labs and get an appointment and wait for 2 days. There was on-site radiology, on-site ultrasound. It was really one-stop shopping. And in addition, if you came into the urgent care center with a problem and you didn't have a family doc, they would do their best to assign a family doc. So over the last 3 years, they assigned 61,000 patients who were unattached family docs, which in this environment is a Herculean undertaking. But instead of promoting that model, what did the government do? They didn't allow them to bill for their laboratory services, which is the most expensive part of that. So they basically, to make a long story short, they went in the hole, the Seymour Health, and the government sued them. They took them to court, did a hostile takeover, and now the whole thing is in shambles. And this is a model that should be espoused and should be allowed to flourish throughout the province. Instead, it's squashed, and it's mind-boggling to me how that happens.
Thank you. Got a question from Mike Wilson. I just want to note, I see some questions now coming in the Q&A. We are now at that part of the evening. I just want to point everyone to the chat window or the chat of the Zoom here. if you would like to make a contribution to either one of the two very worthy organizations and initiatives, the links are there. And I just want to draw your attention back to that. Mike Wilson asks a question, the area director for Cobble Hill in the Cowichan Valley Regional District. This question is to Karen. They're working with some family practitioners, or he's working with some family practitioners to set up a similar community care model as in Saanich, speaking with various levels of the provincial and federal ministries, but it is, to say the least, difficult to get things going. Perfect. Anyway, any advice that you would have would be greatly appreciated. Thanks, Mike. Yeah.
So my advice is to stop trying to work things out with the government. We actually, the medical directors and I at Shoreline have met with the Cowichan Valley Primary Care Society, along with the Cowichan District Hospital Foundation, to talk about some of the issues of getting their organization going. And so, but I'd be happy to talk to Mike as well if you can connect us after this is over.
Sure, Mike can connect with us, absolutely. Excellent. Sanjiv, do you have anything? That was a pretty specific question, so maybe I'll just leave it. Okay, good enough. All right, to Karen again. Should we end the isolation of the Gulf Islands health centers from the rest of the riding? Should Shoreline be open care centers on the Gulf Islands, or maybe Gulf Islanders going to Shoreline in Sydney? Maybe talk a little bit about there is a mosaic of healthcare services that are delivered in Saanich, north in the islands, and it is complex to wrap your head around. It is frustrating to get the government to get sorted out and get straight on, and it's, yeah, anyway, so perhaps from your experience, then I can share a little bit as well.
I have begun to find out just how disorganized, that might be too strong a word, but how not organized things are when it comes to the Gulf Islands. And I've met with someone from Saturna, and I've also met with island health reps responsible for Salt Spring Island to try and move some projects forward. I would dearly love to set up a shoreline on one or all of the Gulf Islands, but right at this moment, it's a matter of our capacity. We don't currently have the physicians or the financing to be able to take on a new space there. So I would encourage people on the Gulf Islands to talk to us. We can provide it at least at the beginning advice, and in a few weeks it won't be up to me anymore. But I'm going to continue to encourage Shoreline to not forget about the Gulf Islands, because it has been, I know, for many people on the islands, a struggle to get medical care of any kind.
Yeah, I think to maybe add a little bit of more texture to what you're saying, Karen. The islands themselves, the individual health delivery on the islands, largely run by volunteer boards. There's people working on each of the islands, obviously, as well, but the delivery of it is on by community health centers. They do a very good job of advocating for the islands and for the communities. But it's fragmented, and recently the different societies have been meeting in my office together and kind of coming together and doing some of that grassroots coordination, because they are in the end communicating with the same health authority and the same ministry, but yet the ministry and the health authority treats healthcare on each of the islands individually and separate, and so nothing is moving forward together. And I wouldn't say nothing. There's limited forward coordination from the provincial and federal government, or provincial government, I'd say. So it makes it very, very challenging. And they're doing good work to come together. But I think they need a partner on the other side that's prepared to address the healthcare delivery on the Southern Gulf Islands and on Salt Spring. Salt Spring Island is except in an exceptionally challenged position. They don't have a walk-in clinic. They don't have enough family doctors. They have enough family doctors. They just don't have enough family doctors providing the level of care. So yeah, and the government's been talking about a primary care network for the Southern Gulf Islands and for Salt Spring. That is an initiative that seems to have just, ground to a halt. So very challenging.
Well, I have to say that it took us, it took several of us 15 years to get Shoreline going. So these things cannot be done quickly. I completely sympathize on that front.
John Trelevin has a point. One irony is the evolution of healthcare in Canada is that we're going back to the future. This was the foundational approach that rural communities took in the 19th century to ensure the availability of physicians. All credit to Karen and the SPHHF for their work. I added a few H's in there to establish Shoreline. How far can we push this model? And then he points to Cambridge, Ontario.
I saw the article on Cambridge, and they've done some amazing work. I think it needs to be taken into account that the system is quite different in Ontario than it is here. The health authorities don't have quite the same, well, there aren't health authorities, and the smaller units that they've got in Ontario don't seem to be quite as intrusive in all aspects of medical care.
All right, Mina Lee Johnstone from Salt Spring is a powerful vocal advocate about the autocentric society, automobiles, and the impact that they have on our society, the effects on health and healthcare, and asked a question about to Sanjiv if you have any comments with respect to the impact of vehicles and on healthcare.
Well, I mean, an autocentric society is clearly the way we've gone, and you can say that if it's about the environment, if it's about healthcare, if it's about NIMBYism, it's a problem. If I had an answer to it, I think I'd be king. But it's particularly evident in public healthcare. Honestly, at the beginning of the COVID pandemic, we were all in this together, and sort of 2/3 of the way through it, it became, well, you do you, we'll give you limited information and just sort of figure it out on your own. So I wish I had an answer to fix the autocentricity of it all, but other than electing more BC Greens, I don't really.
Okay. Back to you, Sanjiv, just about training for physician's assistants. Yeah. Maybe provide a little bit more information about what a physician assistant. You did a good job of explaining how they help and work alongside in the theater of surgery. What is what is the training of a physician assistant? Where do they fall?
It's a good question. So it's very costly, for example, to train a pediatric heart surgeon. Let's just use that as an example, since I can give you exact numbers. So I went to high school, obviously. I did an undergraduate degree for 4 years. I went to med school for 4 years. I did a general surgery residency for 5 years. I did a cardiac surgery fellowship for 3 years. I did a pediatric cardiac surgery fellowship for a year. Add all that stuff up, and I'm pretty old by the time I actually get to practice independent medicine, and it's quite costly. But the person that helped me in the operating room the most when I was in the United States was a physician assistant who did an undergrad, I think, and then spent 2 years training as a PA, and that was that. No residency, no fellowships, no med school, no nothing. And they become very, they develop niches and become very good at the specialized areas that they practice in. So that the PA that I worked with, took an interest in becoming a surgical assistant, and gravitated ultimately towards heart surgery. And she was fantastic to work with in the operating room. That's what she knew. Now, she probably couldn't work in an emergency room or couldn't work in an inpatient clinic for a family doctor. Some of them can if they gravitate towards those areas, but they're much quicker to train, they're much cheaper to train, and they're much less expensive at the end of the day. So utilizing physician extenders like nurse practitioners and physician's assistants is a key and critical way to get us out of this healthcare mess. And we're frankly way behind the 8 ball. Even NPs, nurse practitioners, were not well utilized when I came to British Columbia in 2010. And I mean, there were very few of them. Luckily, that's expanded, but we still don't use them in the capacity that we could across the province.
Awesome, thank you. So to Karen, just back to Shoreline for a minute here. Community health, is it required that a community health center be multidisciplinary? What discipline other than family doctors are part of the Shoreline model?
I'm not sure if a community health center under membership to the associations is required to be multidisciplinary. It is usually considered a good thing, in part because that's the way physicians want to practice nowadays. Shoreline was conceived with the idea of having RNs and clinical pharmacists and mental and social health workers. And we're beginning to get those resources. It has taken longer than we wanted, in part because the way the provincial government did it was not just to say to clinics of a certain size, here's some money, go get the allied health workers you need. What they did was they said, we're going to create a primary care network, and then we're going to control all of the money that goes to the health authority, and the health authority is then going to control all of these allied health professionals who will then be assigned to clinics. And it has been a bit of a bun fight around the table for clinics talking amongst themselves to share those resources. So I would say we're not as far along as we wanted to be, but it's getting better.
So to Camille's question, then, just to kind of explore a little bit further, the UPCCs, the Universal or Ultimate Primary Care Centers, or whatever they're called. What were they called?
Urgent primary,
universal, urgent. Yeah,
they're called oopsies.
The model that the government won't talk about anymore, the UPCCs, they are health authority run and operated, and Shoreline is a community run. And Camille asks a question around the boards that lead the community health centers, that board that you've described as having community members and doctors on it, asking the question, what is the value of having the community input at that board rather than having it be strictly a health authority run?
Oh, no.
No. I'm just asking you the value of having the community involved in it. Yes.
Sorry, that's my knee-jerk reaction.
Yeah, no.
I think she's trying to overcome the stroke of suggesting that something should be run only by a health authority.
Okay. All right, Camille, you got it.
It's really, really important that the community have the control of this. The health authority makes decisions for a larger geographical area, and they have to weigh different priorities. Where if we've got community members from the Saanich Peninsula on that board, then they're looking out for the residents of the Saanich Peninsula. That is why we've constructed Shoreline the way we have. And so there's this balance between, on the one hand, you've got physicians, and the physicians make sure to stand up for themselves so that they maintain their autonomy, and the practice is structured so that it is beneficial for them and can continue to recruit physicians. And the community members advocate for the community, and when necessary, they advocate with the physicians for community issues as well. But the health authority, as much as I admire them for many things, this is not one of their areas of expertise.
I would say Karen gave an incredibly diplomatic answer, because I don't admire them for much. And Halloween's coming up, right? So if you had to make the decision, Adam, that, okay, Halloween's coming up, I need to go buy some candy, you would go to the supermarket and buy a bag of Kit Kats or a bag of Snickers or whatever your candy of choice is, and that would be it. If you ask the health authority to go buy a bag of candy for the children on Halloween, there's going to be 3 board meetings, 5 clipboards, 9 iPads, 6 action items, 52 emails, and at the end of it, you might get a candy bar out of the deal if you're lucky.
Okay. So for Camille, it's a range of we've offered a range of answers here. Dr. Room is a retired family physician, 2 years in Victoria, practiced for 35 years. Asked the questions, why are so many hospitalists required when 20 years ago there were none? So I guess the increase of hospitalists in our hospitals.
Yeah, I think that's a good question. And I mean, Dr. Room probably comes from the vintage that I come from, and my parents as family docs came from, when family docs would go to the hospital and see their own inpatients when admitted. And that practice probably still exists in some rural communities in British Columbia. I wouldn't know that, but it certainly doesn't exist in urban areas. And family docs aren't going to do that anymore. And I think it's just a change in culture, a change in practice, a change in expectations for young doctors who value this thing called work-life balance more. It's just hospitalists have become a specialty in and of their own. And yes, it creates more need. I mean, complexity of disease is also different than it used to be, but I think it takes more people to run the healthcare system these days. I'm not justifying it. I'm just saying that it does.
And just to follow up on that, Dr. Gandhi, the Saanich Peninsula Hospital is one of those little outposts that still has community physicians coming to the hospital to see their own inpatients, and working. The physicians from Shoreline each take a week every 6 weeks and work in hospital to look after unattached patients in acute care. So there's having that kind of a hospital has actually allowed us to recruit a certain kind of physician who really wants to make use of some of the skills from medical school that could only be used in hospital, and have a little bit of variety in their practice. So on the Saanich Peninsula, there are no hospitalists.
Thank you for the answer. Sorry, I was I'm multitasking here as I'm managing multiple. So I want to go back to Saturna, because I think to a great extent Saturna speaks to the part of the rural part of healthcare in our province, and it's really right close to home here. It's just a 45-minute ferry ride from here, but yet I think is an example of the impact that rural communities are feeling right across the province. And as Priscilla pointed out, and as I've come to learn as the MLA, and then as well as visiting Saturna, so much of what happens is done by full volunteers there. So full volunteer fire department, full volunteer emergency response teams. The Salt Spring physicians travel over, and nurse practitioners travel over for a very brief time. The ferries are restrictive. People are growing tired of all of the extra leaning that has to be put in order to keep these services going. And so there's a sense of, we can talk about what needs to be done, what can be done to help fix the system in the future. There are many communities like Saturna and many parts of our community that are looking for some short-term answers. And is there anything that we can think of that can help relieve some of that pressure in the extreme short term as people continue to go around and around with the health authorities? It's tough.
It's a really tough one, because right now Shoreline has a real shortage of capacity. But I mean, I don't have a specific solution. All I can do is continue to advocate within Shoreline for making the Gulf Islands part of Shoreline's catchment area.
Well, I have one suggestion, Adam. I mean, I think incentivizing doctors and nurses to practice in rural areas is imperative, right? So, I mean, Karen said it at the beginning of her talk. I think that the rural communities in British Columbia, and it's not just British Columbia, it's everywhere, don't get their fair shake. And the elitist urban areas of, well, frankly, Vancouver and Victoria really get more of the resources. And to incentivize doctors and nurses to practice in rural areas is something that's been done before in the Canadian healthcare system, and something that should be considered. When we're talking about pouring more money into a system, we need to, again, see results from investments. And if we want to attract people to work in these places, there are people that will work in these places if they're appropriately compensated. There's obviously people that do. I had lunch on the weekend with a med school buddy of mine who works in Fernie. And I mean, he was born and raised in Vancouver, but he loves working in Fernie, a small rural place, and he gets to do a lot of things. It's a great variety of practice, but he's well compensated for it. And I think if we could do that for places like the Gulf Islands, it would be very helpful.
Thank you for that, both of you. And there are two questions here. Medical students from the Saanich Peninsula, two of them, who are Canadian citizens and want to remain in BC. Both have MDs in both the US and Canada, but are unable to get residencies in Canada because they did not go to Canadian schools and are at the bottom of the list for every application they make, even behind foreign applicants. I know this is an issue that comes up regularly in my office. What are the options for these young doctors to stay here and be able to work locally?
Pressure on the College of Family Physicians and Surgeons of British Columbia. The College of Family Physicians and Surgeons of British Columbia has the most restrictive practices nationwide when it comes to accrediting both Canadian citizens who have trained abroad and foreign citizens who are appropriately credentialed. And that pressure has to come from the provincial government. The regulations are frankly ridiculous and at times xenophobic. And so those have to change. We can't continue to have Canadian citizens trained abroad not allowed back into the country, and we can't continue to have appropriately trained foreign physicians driving Ubers.
Thank you. Community health centers. I know. So how are community health centers funded? And part of the reason why I'm stepping up the pace here is because we're getting closer to the end of our session here at 8:30, and we've got a number of questions. So I think we've probably got more questions now than we can answer. So thank you for asking all of these great questions. So I just wanted to go back. Funding for community health centers. What is the funding model? What is the difference between a UPCC funding model and a community health center funding model, or how are they funded? I would say either or. Question to both of you.
My understanding is that the UPCCs are funded directly by the health authorities. So all expenses are covered by the health authority. The doctors are paid on salary at an hourly rate. And so there is no additional cost. A community health center receives funding from the provincial government, but I don't know what percentage of their budget, because I understand that some of them still do collect overhead from physicians. So the physicians are paid directly by the government, and then overhead is collected by the community health center. That is my understanding. I may have some of it wrong, but that's what I have heard so far.
I think another way to answer that question would be, how should these places be funded? And it should be that doctors are signed up with an alternative payment plan, and similarly other healthcare professionals, and the administrative costs are taken care of by government. And I think if you did the math and figured out everything in the end, that would come out as a cost savings.
And perhaps a hospital or healthcare foundation contribution as well, to keep the connections to the community and keep people, reminding people of the great services that the community health center is delivering. Okay, question from Lee York. Please speak to the existing barriers to qualified international professionals and how these can be overcome. So we've had a question about existing barriers for local people to become doctors. There's also barriers for international professionals, and maybe I don't know who wants to take this question, but I'll just throw it up in the air.
I mean, I've had a lot of experience with that, trying to recruit another heart surgeon to help me when I was by myself for so many years at BC Children's Hospital. And frankly, so the BC College doesn't recognize your medical degree as being valid unless it's from Canada. Even the United States is a problem, although there are kind of ways to get around it. But if you're from Europe, forget it. I had highly qualified surgeons from Great Ormond Street, one of the Class A pediatric cardiac institutions in the world, in London, that wanted to come work with me and couldn't because the BC College wouldn't recognize their credentials. So basically they had to get re-credentialed all over again, which nobody's going to do. And the second big thing is the English language examination, which is forced upon every single applicant. And like, frankly, Adam, I don't know if you and I could pass it. It sounds like it's a pretty hard test. And so the need to do that should be eliminated.
I don't know, Sanjiv. I'm pretty gooder at English, so I think I could probably.
Yeah, you're gooder than me. You're gooder than me.
Pretty gooder. All right. So where am I going to go here next? Healthcare units, in my perspective, this is from Elizabeth Dow, need to be a multidisciplinary practice that also focuses on prevention. Professionally licensed social workers are key professionals that need to be added. I want to go back to, I think, something that Sanjiv said, and I think that is at the heart of what the service that Shoreline provides, and that's, well, it's not at the heart. Shoreline provides primary care, but the prevention aspect of this, and the reason why I'm connecting these two is because access to a family doctor, access to a team-based practice, then starts to allow that practice to do more than just focus on illness. It allows, community health initiatives, diabetes clinics, clinics to help seniors, to provide services for seniors. So, I just wanted to talk about the prevention piece of this, because I think that this is a really, really key piece to this, going back to, fix it while it's still small rather than wait till it gets very big. I want to give a little bit more air to this issue, maybe to Sanjiv or to Karen, about the value of that. Yeah,
again, like I said before, prevention is the absolute key to healthcare. And let's bring in the example of cancer care. I talked about this a little bit during the town hall I had a week ago, but when the provincial government announced that they were sending all these people to Bellingham for radiation therapy for breast and prostate cancer, the one thing that was failed to be asked by the reporters, frankly, is why? Why all of a sudden do all these people need radiation therapy, and why is it that the demand is so much greater than the supply? Well, here's the reason. The reason is that radiation therapy is usually used in advanced forms of cancer. It's not primary therapy for cancer. It's either used prior to surgery to shrink tumors, or after surgery for residual disease, or to prevent a local recurrence, cancer coming back from in the same place. And the only reason you get to that stage is because cancer is presenting at a later stage. And the only reason cancer presents at a later stage is because it hasn't been detected when it should have been detected. And who detects cancer early? Primary care physicians. They either prevent it from getting bigger or worse, or to the point where multimodality therapy is necessary. So you can say that for pretty much any disease, whether we're talking about diet modifications for cardiovascular disease, whether we're talking about cancer screening or mitigating the spread of cancer, lots of different aspects of medicine, health style or lifestyle modifications for lots of different diseases that are under the umbrella of family care practitioners.
I'd like to go a little farther because in going to, back when I was with the Hospital Foundation, in going to conferences in the States, I started to learn that a lot of hospital foundations in the States were starting to fund projects related to social determinants of health. And I then later learned that there is a primary health clinic in Alaska that is indigenous based, but a key part of the programs that they deliver is related to social determinants of health. And so what if we started looking at things like food and housing instead of leaving that to somebody else? It's somebody else's problem.
Sonia and I have been talking about, we've got the Illicit Substances in Public Spaces Act that's in front of us right now. The impact that, nobody is choosing to be in a public place using illicit substances. It's a lack of housing that has got them to be ending up where they're at. So housing is, and my mom and I talk, this is a whole other, the intersection of housing and health, I think, might be a very, very good topic of conversation, because we see it in First Nations. Poverty is, and as a result of housing, and then poverty is the result of the children being taken, and the children can't come back until the housing situation gets, and it becomes it is just a healthcare, it's a fiasco. So one more question, and then we'll get Tex to turn his camera back on here and start to wrap up the evening. I wanted to, because I think the question that, oh no, it's gone now. Where did it go?
I answered a couple questions.
I see.
I'm sorry, Adam. I was just trying to get to people. So,
all right, no problem.
Which one was it? Do you remember?
Just the question. No, I forget now. Oh, the question about the health, the different colleges and associations, and the impact that they're having on healthcare outcomes in our province.
So I answered that by just saying the college was the biggest issue in terms of impeding qualification. But I really think that most physicians in this province are all on board with ancillary healthcare providers being credentialed however they need to be credentialed to provide more people on deck. This is a administrative bureaucratic problem, not one on the ground for healthcare workers.
We've got a saying on the top of the whiteboard in the BC Green Caucus office that says, "Let's solve more than one problem at a time." And I think this goes back to the intersection of health and housing, the intersection of housing and criminal justice system. They create these very complex, wicked problems. I did get Mike's email address off of the chat there, so I'll text it to you, Karen, so that you can have it. We really appreciate everybody who joined us this evening, and really appreciate the expertise and the clarity with which both Karen and Sanjiv answered the questions. I think the goal is to continue this conversation with other people working in the healthcare sector, the different parts of it, and so we'll be announcing the next round of guests and speakers, and we'll be continuing this next month and in the months to come. I'm not sure where Mr. McLeod is. Oh, there he is. He is back. I have to go and get Silas from soccer because that's the thing that happens. He's playing under 18 soccer, and for some reason the practice ends at 9 p.m. So we've got to go and do that. And so I'll turn it over to you, Tex. And thank you, Karen, and thank you, Sanjiv.
Thank you.
And actually, I just want to end with this. Today, I had the opportunity to do a 2-minute statement. I just want to thank you, Karen, for the years of service to our community, both at that hospital foundation and at Shoreline, and for the vision and the work that you've done to establish and to leaned in to help establish this in our community. So I just want to raise my hands to you here and to give you gratitude for that. So nice to see you. Thank you.
Thank
you. Okay, to you, Tex.
Thank you, Adam, and thank you, Karen and Dr. Sanjiv Gandhi, for joining us tonight. What a spectacular evening of conversation and understanding. As Adam says, it's a conversation that we need to continue, so we don't see this as ending this evening, but rather continuing with more depth and more understanding. And Camille, if you're still on the line, we'll be out there talking to you shortly. Thank you very much, everyone, for joining us. Please keep in mind Shoreline as a wonderful place to park a bit of money, and you'll actually get a tax receipt for that, I believe, Karen.
Yes.
And we certainly need Dr. Gandhi's voice in the legislature, and whatever you can do to help with his election campaign, please consider doing that. And that brings our evening to a close. I'll just go over to Adam very quickly, but from my perspective, we've had a great evening. Thank you both for joining us. Thank you, Adam. Thank you to everyone who came out this evening. You are what make this work and make it worthwhile.
I'll just say one final thing. We have been posting, the Green Party has been posting these events on their YouTube page. We'll have a link. We'll endeavor to send a link out to the people who joined us or to those who signed up to RSVP. And those who weren't able to make it this evening, we'll send the video to them and to everyone else. I hope we can accomplish that. I think we can. And otherwise, you can go to the BC Green YouTube page, and in the next week or so, you'll see this video get posted there. So that was the last thing for me. Thank you so much for coming this evening, and it's nice to see everybody here.
Good night, everyone.
All right, cool.
All the best.
Good night.